Thank you. Bore da, croeso gynnes I bawb. Morning and welcome everybody. I'd like to welcome particularly Helen Watkins, who is with us today, Director of Workforce and Organisational Development, who observed this meeting. Welcome to Kirsty and Anton, who are joining us online. I'm been advised of absence, apologies for absence from Dawn Jones, one of the independent members. I haven't got any other apologies. Okay, again, I haven't been advised of any specific declarations of interest, but if anyone has any that they wish to declare at this point in the meeting for items that we're going to be considering this morning. No? Okay, none received. Thank you very much. Okay, so if we can then move on to the draft minutes of the committee meeting held on the 5th of September. If we can do those for accuracy first. Page 1, 2, 3, 4, 5, 6, 7, 8. There are no comments on those, then I those off as accurate record. And then if we can move on to the action log of the 5th of September. David, we've got 2 actions, but I believe they're both
committees are
on the agenda. Thank you. So then if we can go back to the minutes of any matters arising that aren't covered by this morning's agenda. Again, page 1, 2, 3, 4, 5, 6, 7, 8. Okay. No matters arising that people want to bring forward. Okay, so we will definitely accept those as a true and accurate record, sign those off. So we can move then into part 2, which is the education performance and quality section. Now, I have been asked if we can just slightly amend the running order because I believe you are you're double booked and have another commitment. So if we could take the dental report first.
Thank you, Chair, and thank you for letting me join remotely. I'm in the dental school in Cardiff this morning, so I just stepped out to come and present to you. You'll have received the paper for the committee to note the updates. I don't propose to go through it verbatim. Foundation fill rates are good. As I reported at the last meeting, our challenge with foundation training is the number of practices holding NHS contracts willing to train, so we're working to address that. Dental core training, there is a typo that I just want to draw your attention to on the table. On DCT3, posts filled via local recruitment, that should be 6, and then the total should be 18. So there was a small typo there to draw your attention to. But we work closely with health boards on the locally appointed posts that don't fill through national recruitment. Specialty training, we had a significant increase in dental specialty training in 2023. So we have 34 posts currently, and we are filled them all, which is really good. And 8 of them are in collaboration with the dental school here in Cardiff, actually. We're working to increase the academic trainees in some very small dental specialties. Dental therapy foundation training. So this is a year post qualification for dental therapists to work in the NHS general practice. We've not filled as many this year for multiple reasons, and it's not unique to Wales. The same is across the UK, where they are running foundation therapy schemes also. We are working closely with dental schools. Some of this is that there was less graduates this year because of the bulge that came out last year because of COVID. So there are multifactorial reasons, but we are working closely with the dental school to try and improve that intake, and we would hope to see a fill in 2025 because we've increased the numbers of commissions at undergraduate level as well. Undergraduate commissioning for hygiene therapy, that's ongoing. We work closely with Cardiff and Bangor regarding the dental therapy and hygiene programmes, and that's part of the reason why I'm in the dental school today, because they're proposing new curricula across all of their programmes that we are working with them to make sure that we get the best experience in terms of interprofessional education and placements. I don't propose to go into too much detail. Dental nurse training, they sat their final written exam just 2 weeks ago, so we're awaiting the results of those, and then that will decide whether they can go on to the practical elements of the exam for dental nurse training. with no ARCPs apart from dental specialty to report, and that's in the paper for information. Trainee forum and trainee survey. So these are key areas for us in terms of our quality management and oversight of programmes. The dental trainee survey for 2024 closed, and we're just analysing the results, and these are the headlines that you have in the paper here. We need to do a bit more work digging into some of these. 74% response rate, which is an increase, which is positive. And generally the feedback was very good. 89% reporting that post good quality, 87% enjoyed it, 92.7% would recommend the training scheme to others, which is really positive. Some things that we're addressing, the shared services pops up as an ongoing challenge, and that part of that is the understanding really of who's responsible for what in the single lead employer model, where we operate the training but the employer does the employment issues. So we've just completed 2 webinars for all incoming trainees with colleagues in shared services where they present and talk through, and that is an improving position, but we will continue to work in that area. Workload, there was some concern around workload, and I think probably reflecting some of the challenges in general dental practice at the moment, particularly for our foundation trainees and dental therapy foundation trainees. So we're going to dig a little bit deeper into that to find out where the specific issues are. We can report back. Teaching and learning's fine. Some issues with challenges where we've got trainees who have to get up to Merthyr Tydfil for a placement, and particularly across North Wales where some of the public transport. We're seeing an increasing challenge there where graduates come out and they don't less graduates drive them than used to, and so getting sometimes from training placements to where their study days may be held, or even just getting from where they live to their training placement is a challenge, but we work with trainees to try and address that where we can and lift share and encourage that. Culture, we've 16% of trainees experienced or witnessed bullying, harassment or discrimination. This is a key finding that we need to dig it. I've had conversations around this. We are going to go back into the data and identify specifically where that is and what programs those are on, and whether we can go into a little bit more detail there just to unpick what that looks like and what that means and where there are concerns and what action we need to take. So we'll report that back to a future committee. And then less than full-time trainees. We only have, I think, 4 trainees, 5 trainees on less than full-time, but we will again dig a little bit deeper into that just to find out what the specific issues are in there. So national recruitment, that we would expect to see that because we're increasing our numbers of local recruitment through our enhanced scheme, and we recruit all our specialty posts locally apart from orthodontics. So there is a real mixed picture there. Welcome to Wales. We held 2 face-to-face events, one in South Wales, one in North Wales, for our international dental graduates. We're seeing an increase in the number of trainees that are coming into dental programs who qualified overseas. Some of them might be UK citizens who went to do their dental training in Europe, and then they come back to work in the UK. So this is an increasing area that we're going to put more material and more education and training in to support this workforce, and it enables the trainees to develop peer groups and networks as well. So they might be coming into Wales for the first time from wherever they've trained. So we're doing a bit of work in that space, 2 face-to-face events, but we need to do some work measuring how successful they are, and the benefit and impact of those. We've also arranged 2 specialty trainees reported on the previous survey that they felt a bit isolated because they were working in their particular specialty and not having much engagement. So we've worked quite hard to establish trainee networks and trainee face-to-face days, and these have been incredibly well received. And there's another one due next week. Quality assurance, the general dental specialty curricula, they've now been approved, are in place from September 2024 across all dental specialties. We've got very good representation with the colleges. The 4 Royal Colleges are all working together on the summative assessments and what they will look like for the trainees. And our Associate Dean for Dental Core and Specialty Training is also vice chair of one of the Royal Colleges, so we get some really good flow of information in terms of what happens with the trainees. We've worked hard to make sure that the training program directors and educational supervisors are all fully informed, and we've held a face-to-face event to inform them of the changes and the transitionary arrangements around that. I think that's it. I'm happy to take any questions. Thank you.
Most people that update. I'll look out questions. Judith.
Yeah, thank you. I've got two specific ones, Kirsty, for Steve, and one more general one. So my first specific one is on page 24. It's at the bottom of the page, which is, I think, page 2 of your report, which talks about the local appointment trainees. I just wanted to understand why these people can't attend study days and what's the impact of that. Well, I don't understand it, so I wonder if you could explain that and why it's like that. My second question is relating to the transport challenges, which is page 5 of your report. I just, maybe not for today, but I would like a bit more on that, because that effectively means 33% of trainees are saying they've got challenges. And if they can't get places or it's too difficult, it's not great for them to, be able to continue. And if there are people who are in more remote areas, which is what you say, that's so critical to dental service. I just felt as though maybe that needed a little bit more explanation, not necessarily today, but that'd be great for perhaps an update in your next report. And then I would just like to know what's happening about the potential for another dental school or dental training facility. It's my particular area of interest in another part of Wales than Cardiff.
Thanks, Judith. So I'll start with the first question. So the local appointments for training. So this is a key area that we are looking into. So what happens is most of our posts go out for national recruitment. If they don't then fill via national recruitment, units might decide to then locally recruit into those posts, either because they've got somebody in the workforce or they can't recruit through national recruitment, so they recruit locally. There's been a lot of work done for this particular workforce because we are seeing an increasing number of these, and they previously didn't have access to any support at all. So we've put in place that they can work with the development portfolio. They have assigned educational supervisors. Their local appointment, the attendance of study days, that's a historical. I don't. And again, this is an area that we need to address. I think it's more to do with the local appointments and the local employment arrangements than it is with HIW's ambition. I don't think we actively stop them attending study days. The offer is there, but it's definitely an area. So we've just recently appointed an Associate Dean for Dental Core Training specifically to address these issues and work more closely with the local units to improve the offer for the locally appointed positions, because a lot of them are overseas graduates that are coming in and not really understanding the system. So we're supporting them in that respect as well, and try and improve that offer and improve the interface, I think, across all of them. I mean, what we would like to see, Judith, give some assurance, is that all of our dental core training posts are offered as dental core training posts and are filled as dental core training posts. But it's a little bit of a mixed landscape that we're just working through at the moment. So that's the local appointments. The transport challenges. So this is something we're seeing increasingly. And if I start with dental foundation training, we do need to dig into it, and I'd be happy to come back to the next meeting and talk a little bit more once we've gone into it a little bit further. It first came up about 2 years ago in respect of dental foundation training. So we recruit via national recruitment, and trainees are placed, through national recruitment on schemes that they might not be familiar with, etc., and they might not be even familiar with the geography of Wales. And less graduates now are driving than previously did. There's less people learning to drive, less people driving. We need to get into where these, as you say, 33% is significant, and we need to get into where this is an issue. We know it's an issue between trainees who are on a Swansea scheme, for example, who have to travel then to a training day potentially in Merthyr Tydfil, because the transport links between those two are just not there, public transport. So we've worked with them to do car sharing where that's appropriate. We also then have put also out into the job descriptors for national recruitment for these posts that this is a requirement. So being able to travel is a requirement, and we'd like to encourage that, and that's a consideration that needs to be not a barrier by any means, but it's a kind of you need to know that potentially being able to travel is a requirement. So again, I can't give you detail around this because we need to go into this and we need to look into it further. But I suspect it's dental foundation training, because they're placed in practices that are out where the core and specialty tend to be in hospital units, whereas foundation training tends to be out in practices, some of which might be a little bit more remote than others. So let me get the information, and then I'll come back to the next meeting with an update further on the transport challenges.
Just to say, I'm really concerned that we're saying people have to travel, because if you don't drive, that could put you off applying for a post that's a bit further away. But anyway, if you could look into that maybe next time, because I'm just worried about specifying that as part of the criteria.
I just
need to fine, but not if you don't, you won't be able to work there. Anyway, perhaps, as I say, not prolong it there.
I'll correct myself though, Judith. It's not that they have to drive; it's making them aware that travelling potentially will be a requirement. Yeah. And then you also asked me another question about dental school.
Sorry, I shouldn't say the name. Somewhere outside Cardiff.
A potential for a dental training unit. I don't have any further update on that. I know there are discussions, there are ongoing conversations around a potential dental school in Bangor, and one of the members of Senedd did do a report and commissioned a company to do a full report for a dental school in Bangor. I am told that the chief dental officer that the minister is still keenly interested in this and would like to get in this. And I think Bangor are having conversations with Aberystwyth around what that looks like. I am also, because I'm in the dental school today, aware that the dental school are working quite closely to get outreach placements in Hywel Dda and in West Wales through their undergraduates. So that's also, those are also live conversations that are taking place at the moment. But I don't have any further update in respect to the dental school, Judith.
No, that's fine. Thank you very much.
Thanks, Kirsty. Jill.
Yeah, thank you. Thanks, Kirsty. Really clear paper. Just a few quick questions. On that local issue, are we happy that we've got consistency and oversight of the ones that aren't appointed centrally? I'm just a bit nervous about this two-tier bit of the locally appointed versus the central, and not on this single lead employer. So I just, you don't have to answer now, but just something for the future, really, in terms of our oversight and consistency. On the single lead employer, we do seem to have been trotting around this for some considerable time now, and I hear what everybody says, that it's an improving position. It still doesn't feel like we've nailed it yet at all, and that applies to not just dental, it applies right across the piece. So I still want to flag up that I've still got a remaining concern about single lead employer. And then the final question was, I'm spinning through to another paper further on, where we say that we've now got much better data, much more information. We can look at the financial implications of all this. But yes, we have at least 4 reports, I think, today that say there's no financial implications of any of the things that are in there. And I just don't think that's the case. There must be financial implications of some of these things. So I think it's one. But I'll probably raise it up the times, I suspect, this morning. But I think if we are going to get better at the implications of not putting posts with different arrangements, then we need to be clear what the effect of that is. So you don't have to answer any of those, because they're just comments, really.
Kirsty, do you want to come back to Jill?
If I may, thank you, Chair. In respect of the local appointments training, Jill, I absolutely hear what you're saying, and it's something that we've been working quite hard to improve the position of. We've worked quite closely with the health board recruitment teams. We've put in place SOPs to standardise processes, because there was an issue with them being paid the wrong amounts, being employed on different contracts, and it was very much an unequal playing field. So we've worked quite hard to improve that. I don't think it's perfect yet, and as I said to Judith, it's still something we're addressing. We've appointed a new associate dean who will start in January, and this will be very much within their scope to address. And I hear what you're saying about SLE and the financial reporting, and we will take that away for due consideration. Thank you.
Any other questions? Just a couple from me. And I know you said there was a typo at the beginning. I wasn't quite quick enough to find it in the paper, Kirsty, so apologies if it was this point. But it was the on page 4 where you talk about the number of dental hygiene graduates and where they're working. Of the 18, you say 8 were in the private sector and less than 5 in the NHS, which then doesn't add up to 18. So I kind of wanted to know what happened to the others that had graduated, and if we knew. So that was, yeah.
Go on.
Answer that one first, Kirsty. Then, yeah.
So I think at the stage they were asked, they didn't know where they were going. So I think that's the output there. So it's almost like an exit survey. They were asked at the point of graduation where they're intending to go, and I think they didn't have that clarity. But anecdotally, we know, and this is again a UK-wide challenge, that dental hygiene graduates are going into the private sector. They're quite open about it. They're not making any, aesthetics, cosmetics. It's where they're going. So dental therapy is kind of where the focus is in terms of increasing the workforce in that respect, because dental therapists can also do dental hygiene.
So I thought that might well be the answer, Kirsty. So thank you for that. And that kind of just touches on again something I was interested in. Again, this is more a comment than needing to a response on. But I thought it was interesting that we were looking to expand the access to dental services, obviously, and I thought it was interesting that dental therapists are able to undertake, it says in the paper, around 70% of the work of a dentist. And I think given some of the discussions we've had in other forums, the acceptability and whether that is in a situation whereby the profession recognises that too, because that is, obviously something that will assist greatly in expanding provision services. So again, why there may be a difference potentially?
So this is very topical, actually, Chair, and I watched the other conversations that are going on elsewhere in healthcare with interest, because this has been a live discussion in dentistry for probably 10 years now. Professor Paul Brocklehurst, who's a dental public health consultant based in Public Health Wales, did a presentation on Tuesday exactly on this issue, skill mix. He's done a lot of research in this space. Patients are very accepting, they make no difference as long as they're informed when they come in that they are being seen by a therapist. They have the patient acceptability is fine. The profession is mixed, and I think there's ongoing work to try and educate the profession. The key driver in properly utilising skill mix and utilising them effectively is the NHS contract, because at the moment only a dentist can be a performer and a provider. There has been provision made that hygienists and therapists can now undertake treatment within the contract, but they are still, they don't have the same, they're on agenda for change, so they're not on the medical and dental salaries. They don't get the same benefits in kind as dentists. So there's a little bit of work still to be done at policy level to try and level that playing field. We've got work going on where we train, we've got a foundation training scheme for therapists. We also do a skills optimizer self-evaluation tool that we do facilitated in practices to improve their skill mix position. And that was the output of a piece of research we were involved in a few years ago. So it's an evolving picture, is what I would say, but it's definitely improved from where it was even 5 years ago.
Thank you, Kirsty. So if there are no further questions, we were asked to note the paper providing the overview of current risks and exceptions in relation to postgraduate dental training and HI's actions taken to address these for assurance, and note positive exceptions in progress. Could I just add a couple of things that we said that we'd like to bring back, which was the update on transport, and I specifically also want to see something around the trainees, 16.2% that trainees experienced witnessing of bullying and harassment. And you said you're going to do some further work on that, so I'd like to see that included in the next two. But thank you, Kirsty, for your update, and enjoy your time at dental.
Thank you. Thank you.
So if we can go back to item 2.1.1, which is the medical update. Anton, I think you're presenting this.
Thank you, Chair, and thank you very much for facilitating me doing this by Teams. I hope my voice doesn't go in the middle. I'm going to talk you through very briefly our medical deanery quality update for assurance. I hope the paper speaks for itself. It's not been that long since our last update, but there has been quite a few significant changes. So I'll just touch upon some of them. I'm not going to pause on our annual education, training, commissioning and quality meetings, which has just come to a conclusion. These are meetings that happen annually, was initially medical driven, is now multi-professional. It's an opportunity for very high level, usually CEO to CEO discussions about a broad overview of training and also looking at some of our standards that we're proposing to bring a report on the outcomes, themes and next steps from these meetings to ECQC in the future. There is a few things that I do need to bring your attention to, and you will see in the report, and I'm sure that you're well aware that there's been some infrastructure issues at the Princess of Wales Hospital in Bridgend, and those infrastructure issues will have an effect on education and training. Already has had some effects, and we are working very closely with CTM UHB on managing trainees who are affected in that.
Yeah, and so we're struggling a little bit. It might be because of the mic. It's sort of you're going in and out a little bit. If you kind of sat a little bit closer, but and stayed still, it might work a little better. Because we are struggling a little bit.
Excuse me for a second, and I'll plug my headphones in. Sorry.
Yeah, it's better when you're closer, Anton. It did sound well when he said his voice may give up. It's yeah. 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 Hope we haven't lost you completely, Anton. No, it's still there. All right.
Is this any better?
Yeah, I think it is. Yeah. I don't. Yeah. Hopefully, sounds a bit better. We
Okay.
did have, but yeah, it's just a bit tricky.
Sorry, apologies. I've got the headset on now. Please just interrupt me again if I'm not clear.
That's much better.
Okay. I was talking about infrastructure issues at the Princess of Wales Hospital in Bridgend. We were notified very rapidly when it became clear that there's infrastructure issues. The health board's working with us very closely. We're working with our training program directors, foundation program directors and heads of schools to make the training experience as good as can be for the trainees affected in that area. And we're actually meeting weekly at the moment to talk over that. So that is an ongoing challenge, which I think will go on past this ECQC meeting. In terms of recruitment, I've got mostly good news. We have filled general practice training, but not only have we filled it, those trainees that have taken up posts have scored higher in their entrance exam than previously. And I'm not 100% sure what that means, but it may mean that we're attracting good candidates and we will feed back on that. Secondary care recruitment, as you can see, is progressing well with a 92% fill rate. You will remember from our previous discussions that the Medical Foundation program was oversubscribed, so we're reporting 102% subscription rate. And of course, Foundation 2025 has already started, and it's likely that there will be a oversubscription again. That will have to be managed. We will come and report to the exec team and also to ECQC our approach to that. In the meantime, we have started to have meetings with the PMA and those doctors affected by the late notifications last time, so that we can learn from that experience. Medical education infrastructure, especially trainers, is something that we touch upon lots, and I think we will do so again. Our current education teams have had their induction, and those posts, especially in our local posts, the faculty lead posts, are currently all filled despite all the pressures on that post. There has been some changes in quality management. only one targeted, well, it's now 2 targeted visits has been undertaken in this reported period. And currently there are 3 departments in enhanced monitoring status, and they're in the paper. So this is enhanced monitoring. That is something applied by the GMC in discussion with ourselves at HEIW, but it is the regulator that applies the enhanced monitoring status and will lift it when they feel assured that it can be lifted. And those are the ones listed there, which is general internal medicine throughout ABUHB. We have noted some improvement, but the regulator will want to be assured of sustained improvement before they lift that. Emergency medicine at Prince Charles Hospital and cardiology at UHW. All of those areas have got clear action plans with a clarity of what will be required for de-escalation. Emergency medicine in Betsy at Wrexham have noted significant improvement, and a request from ourselves to de-escalate from enhanced monitoring has been agreed by the regulator, and we're very pleased with the collaboration and the progress that's been made there. Obstetrics and gynecology in Swansea Bay UHB and general internal medicine in Prince Charles have received letters from the regulator, not to enter them into enhanced monitoring, but to notify them that further progress needs to be made, otherwise enhanced monitoring will be considered. So we will follow up and arrange visits. Then I've listed the high-risk concerns that has got scheduled reviews. And then we've also listed some changes that's been made since the last report. General medicine in Prince Charles has got follow-up arrangements. We've talked about obstetrics and gynecology in Swansea Bay and the fact that they've received that letter. Cardiothoracic surgery across Wales has been delivering evidence from multiple sources that there is a challenge around curricular delivery, trainer capacity, etc., etc. In Cardiff in the Vale, there has been other issues relating to training opportunities and curricula, etc. There was a follow-up meeting after this report was submitted last Friday, the 8th, to Cardiff in the Vale, in which we did not note significant progress. And so there has been a summary of the findings and next actions shared with the exec team at Cardiff and the Vale, and early discussions with the regulator around the possibility of enhanced monitoring is taking place as we speak. And there is a significant risk that cardiothoracic surgery at Cardiff and the Vale is placed into enhanced monitoring by the regulator at this time. We said that we would report on the high level themes from the national training surveys, and they are in the paper. It's really important to note that just about 80% of all of our trainees are very satisfied with their training. We have a very high response rate in our training surveys, and so we can know that this feedback is reliable. There are a lot of data in these reports. There are many hundreds of thousands of data points, and what we are doing is working through all of that together with our health board and school colleagues. There are areas of improvement across the surveys, especially in general internal medicine. The rest, I'm happy to take questions on. There is one new area. There's one area that we did not expect to see, and that was hematology, which is across multiple sites. We have an action plan in place to go and understand why we have that findings from the national training survey, because of course it doesn't tell us what the problem is, it just tells us that there is a signal of something. So we are busy working through a plan to get more data. In terms of bullying, harassment and undermining, Wales's results are similar to those of the other nations. So around about 70% of trainees report that their working environment is supportive, and that is good. I have put in a paragraph around the Speaking Up Safely group, co-chaired by the medical director of HEIW and Shared Services, and the actions that we're taking via subgroups to promote speaking up safely, especially around sexual assault or incivility, and the actions that we will take when this comes to light. And we always do this through a formal tripartite working arrangements between ourselves, Shared Services, and the host organisation. In terms of the trainer surveys, Wales is not dissimilar to the rest of the UK. Time for training and burnout are things which are a risk in our trainers, but also in our trainees. And it seems that those at a high risk of burnout is increasing across the UK. The approach that we take following the surveys is detailed on page 7 and 8, I think. I'm happy to take questions on that. In terms of trainee governance, in this last period, you can see that we've had 7 appeal requests, and those appeals have been dealt with or managed within the appropriate timelines, reviews, appeals process, and panel composition. In terms of the regulator,
I was just conscious a little bit that I know we've got people wanting to come in with questions. So, and I know your voice may not last out, so I'm hoping we can get plenty of time for questions if that's okay with you, because we obviously got to pay for that.
I am finished.
Yeah, lovely, thank you. Right, so if I can open it up to questions, Jill.
Yes, thanks, Anton. Very comprehensive. Just a couple of quick questions. The Minister's or Cabinet Secretary's just recently published a new intervention and escalation arrangements. Do any of our escalation issues feed into that process at all? Is there any opportunity to feed into that? So that's my first question. Second question, the second is a comment, which is about the financial implications, which I'm sure you expected me to say, but there are some considerable financial implications in some of the things in here, the number of visits, the rotas for cardiothoracic, etc. So that was my second comment question. And the third was about the appraisal rates that I'm sure Judith was going to raise if I didn't, and how we try and move that forward, because trainers who aren't getting appraisals doesn't look like a good look to me. So so I just wondered how we were going to move that forward.
Anton?
So, I think I can answer those questions quite rapidly. So in terms of escalation, we have a mechanism for communicating both with the Chief Medical Officer, the Deputy Chief Medical Officer, and with somebody now in the NHS exec when we are placing a program, specialty or health board into enhanced monitoring. So we've now agreed a process for sharing that information with our Welsh Government colleagues, both within the office of the CMO, but also within the NHS exec and the performance and escalation folks. So that's the first one. The second one was around the financial implications. And I think the financial implications, there are financial implications for everything that we do. I don't think I'm going to be able to answer that today. And the third one is about appraisal. All doctors, whether they are in training or working in Wales, have to have an appraisal. So we know they're having an appraisal. We have worked very closely together with, and we're lucky in Wales because we only have one appraisal system. Within England, of course, there's access to many, many different appraisal systems. We've worked very closely with our colleagues in the health boards and with our colleagues in the RSU to build self-reporting into the appraisal template. so that folks can identify themselves as trainers. And we've got a drop-down list. We've also developed an appraiser module for folks who are appraising people who are having an educational appraisal, and that went live, I think, last week in English and Welsh. Of course, the skill of an appraiser is to appraise someone in every role that they do. And so there's more work to do in training the appraisers and, of course, making the appraisee aware to bring this up to the appraisers. But we are working on this. And everybody is having an appraisal. It's just that I think we can work on the quality of their appraisal in the educational sphere. And remember, it has to be done as part of their whole practice appraisal. I hope that helps. Thank you.
Judith.
Yeah, can I just carry on that question a little bit? Because I'm glad of your confidence that everyone has an appraisal, because that's not my experience on the ground, but never mind. But another aspect of that is job planning. And I know for a fact that job planning rates are variable across Wales, across health boards. And I just wonder where that comes in a conversation, because if a trainer does not have a job plan that enables them to have the specialists to do that role, then that may be, I don't know, but maybe a causation of some feedback. So I just wondered where the conversations with health boards about job planning fit into this. So that was one question. My second point actually is to do with the enhanced monitoring, etc. And I suppose it's partly to do with the quality management system you're setting up and about this triangulation, because I noticed that Cwmtach Magariog have got 6 areas of either enhanced or concerns, high concerns. So they're referenced 6 times. Later on in the papers, we hear about concerns over midwifery and the possible impact of students choosing not to do the midwifery training there. So I just wonder at what point does, and maybe it is this thing about feeding into the management exec, at what point does this become a greater escalation? Because we appear to have a health board that is to some extent a bit of an outlier. So that was one thing. And the same point about escalation concerning cardiology or cardiac surgery, because again, later in the paper, we talk about issues around cardiac physiology, which is in the same area. So I just wonder how whether your quality management system will pull those together, and then what is our role in actually moving that forward to improve the experience of trainees?
Okay. I need to try and remember what the first question was. The first question was going back to appraisal, and then job planning. So, of course, all of our trainers are employed by health boards. All of them have signed up to agreed tariffs for educational and named clinical supervisors, and we know that about 2/3 of trainers regularly say that they have access to that time, but that means that 1/3 doesn't. So where we get feedback regularly that this is the case within departments or within organizations, we discuss this at the level of our faculty teams, our schools, and with our with the assistant medical directors and the directors of medical education, and we work together. If we have a department that is showing signs of, how shall I put it, insufficient time for training and is underperforming, that comes out within the quality management system and becomes a recommendation specifically. Time is, and I will not say that time is not a problem. Time is a huge problem in training. I accept that. But we are working to try and ensure that our trainers have adequate time to train. That's about time for training. And around the triangulation, I think probably both Malcolm and Tom will say that the feedback within organizations change, and it changes frequently. And so sometimes some areas have a lot of people in enhanced monitoring and then it changes. However, where themes emerge, we can always escalate further beyond the routine quality management process. For example, we've previously looked at an entire health board, and I will use the example of acute internal medicine at ABUHB, which we'll set up a task and finish group and look at that across the whole organization. Similarly, in issues in cardiothoracics, we are looking not only at the quality management, but at program management, the infrastructure, the health boards, and putting a group together to look at it holistically across the training programs and how that is delivered. So yes, this data does lead to not just quality management activity, but further activities afterwards when it becomes clear. I hope that answers the question.
Yeah, it does. That's very helpful. Thank you. Yeah.
Lisa.
I just wanted to add to that, to be fair to Anton, I think that your question about escalation, and it probably relates to every aspect of GP support and everybody how we do it. So one of the things that you will say to you, obviously, as an organisation, we've actually been asking for quite some time to have IPPD activities to develop.
Yeah.
That happened for the very first time in last Friday. Okay.
Delayed again.
Actually, and in a way, no, it wasn't delayed. And as a result of that, to do the presentation that we did, actually did include all these escalation resources, which is actually quite reassuring. That's the mechanism. But nevertheless, actually, Welsh Government are aware that these escalated areas anyway. That's the formal mechanism that we've now got to put those in. Within the quality assurance arena as well, that you think that Anton made reference to actually how we have sort of quality assurance meetings that you with the health boards. And of course that started actually from a medical footprint to begin with, and now it's expanded, and that affords that opportunity clear once again. Those are the conversations we had with the health boards. And the other one actually as well is that on a 6-monthly basis, if the obviously health inspector will always have a summit where we are invited to, and I know Malcolm actually attended from the medical community, we actually attended from that quality aspect, and that information is actually shared there. But all that information has already previously been shared with those respective organisations anyway, whereby, yes, you actually mentioned the video 3 actually, which we will come on to. Once again, it's that triangulation between ourselves, the university, and the health board, which is absolutely key in actually raising this kind of concern. But just to put that
really helpful.
Yeah,
thank you. So if there are no further questions or comments, we're asked to note the contents of the paper, providing an update quality postgraduate training for students. Thank you for a comprehensive report, Anton. I just want to pick up before we forget it. Jill's points, because they are all very comprehensive reports, but as Jill has noted, sometimes I think that section on finance just gets overlooked a little bit. So if that can be given some due consideration for reports moving forward.
Yeah, just on that point, I think probably we're looking at that financial implication through a different lens. It's like new funds for us. I think
exactly.
So maybe it might be want to understand broader financial implications across the system.
Yes, I think it needs to be separate.
But I think that's the reason why people are trying.
Yeah. Thank you, Anton. Right, so we're now moving on to 2.1.3 pharmacy. I'll just remind presenters that we've had very comprehensive papers, and if there are a couple of key things that you want to draw out, my colleagues will have read these papers intently and will be keen to ask questions. So, Margaret.
You always come to me, I will keep it brief. But I do want to pick out some key things. So there are key issues that I mentioned at the cover paper, the potential regulatory changes to our initial education and training pharmacy technicians, our numbers of trainee pharmacists, and how do we start thinking about how do we train and not meet workforce demand, and the Princess of Wales structure and issues. Princess of Wales, I can say we have no concern, but working very closely. There are no trainees who are being impacted negatively about that, so that is not a concern. I do think hopefully the paper articulates that one of the biggest challenges for us is to be able to plan through data and lack of data, both from the point of view of retention, recruitment, planning for our recruitment, how many numbers do we need? That is something that I'm talking internally. We're hoping that picture will change in the next financial year, but I do need to speak to my colleagues internally about how we can start really using, when that data becomes available, how we can bring that in and then use it for better planning. I wanted to highlight that it hasn't been in the paper before, but I've mentioned undergraduate numbers, and that does have implications for us. I mean, it's pleasing to see that there are increasing numbers of people applying to schools of pharmacy that are oversubscribed. So undergraduate numbers in Wales are increasing, and that has implications for us as SEB, because we do fund clinical placements and we have a quality framework wrapped around that as well. But it does mean that at the moment, the number of trainee pharmacists that we have will not meet that demand in Wales if we would start thinking about. So we have pressure on both sides. I look at it as a bit of a sandwich for our trainee pharmacists at the moment. We have an increasing pipeline coming through. We have vacancies on the other side. And at the moment, we've been in a state of maintenance of our numbers. We haven't been increasing. So that is a piece of work that is being presented to execs next week, I think it is, to really look at, we need to start thinking about a phased approach to how do we increase those numbers. So I think those were really the key points that maybe you haven't seen, haven't heard before. So recruitment, retention, we really need to have better data for us to be able to really nail what it is we can do. We are doing things in recruitment and retention, but with better data, we could really challenge that further. The implications of GPHC changing the initial education and training of pharmacy technicians, we need to be very close to that, because the indications are that the regulator will be looking at SEB's involvement in overseeing that approval or quality management of those trainee, that training programme. I think it's really important to note as well, to recount that data, the fact that we do not know how many people are training pre-registration pharmacy technicians in Wales. We only know people who are coming through our programme. So we're completely blindsided on the rest. So again, planning for how many do we need to train, we don't know. So one of the things I just wanted to say at the end, because I just feel I want to share good stuff as well, is we are getting some really great stories on the ground about how the changes we've made, the infrastructure that we've put in different workplaces to transform education and training is also transforming teams. So we've got some really great impact story, both in community, GP practice and hospital, where they're saying, we train these people, it's helped us to develop our own workforce, it's helped us to understand what a pharmacy technician do. I've now got a pharmacy technician in my service because I understand what they go. So I've got some really great stories about the impact that our investment is making, not only in developing the current workforce, but changing how the workforce operates. So that's me.
Thank you, Margaret. And I think I share with you that sometimes we do need to hear those positive things too, particularly this. Sometimes within this committee, we hear the other side. And so it is really important that those have an airing and are shared, and it's great to hear that. I'll open it out to questions. So Lisa first, actually.
Can I just actually really congratulate you there, because it is so important to work with the current workforce to understand new ways of working. Yeah. That is so important actually when we develop these actually transformation goals. So well done, actually that is. I would also recommend that you can probably at some point have it as an improvement story to the board.
Yes.
Know that recognition of that change. It's really good.
See, very good idea, Lisa. I'll support that and so yeah, thank you. Judith.
Yeah, thank you. Thanks so much for the paper. It's really clear, and I think the work you've done in this area is phenomenal, actually. I just wanted to ask this, expand a bit what you said about the pharmacy technician, the fact we don't know about them. Who has got the ability to change that? Is that something HEIW could influence by the costing or driving forward a change? Because it just feels, in it just feels really difficult if you haven't got access to those numbers. But
I'm part of the Conference of Pharmacy Education Deans, and we have been pushing the regulator hard to say, because the regulator doesn't even know where these people are training. So they don't know until people come in to register. They have no idea because they don't have training numbers, which they do for pharmacists, training pharmacists. So they have no idea till those people come through to registration. They don't know where they are. So they can't tell us the information. So we've been pushing hard to say, as part of these changes to the initial education and training standards, they need to think about, if they want SEB's involvement, we need to be able to have that visibility of where people are training and what training they're going through, either to support those people or just for our more efficient planning. I actually think SEBs, we should be part of that approval process, because what we do know in Wales, we have engaged historically with a provider, pre-reg pharmacy technician training. Quality was very poor, and we had to actually disengage with that training program, and now we have a different training provider. So we know that not good quality is happening out there, but the regulator doesn't oversee any of that. They just approve the program and assume it's all okay. So it is extremely, so your answer to your question, Judith, we are pushing the regulator very hard to say it's not acceptable. Collectively across the UK, so it's not just Wales.
No, okay. And we could do something interesting in Wales to try and do the route with pharmacists or health boards.
We could influence health boards so that we could actually say these are the only programmes that we feel are fit for purpose in Wales, by not being on the procurement list that they can buy. But from the point of view of community pharmacy, because
okay, that's really helpful. Thank you.
Yes, yeah, just a couple. Thank you. Really clear paper. I still get a bit confused by the payments for placements in the various professions. So I suppose my question was, are they sufficient for pharmacy? Because I know we had a conversation many years ago about the differences that were paid. And it's a question, second question really relates to next paper as well that's coming next, which is I've had a bit of a thing about the independent prescribers, as you know, and I've lost count of the number of people I know who don't use their skill. And I suppose it was the same sort of theme in the optometry paper, which is we're training people in advanced skills, same in Lisa's area. And at some point, obviously, we've always said that we need to show the value of our added training. So I've written an equation down, sort of investment equals what, and how do we have oversight of that? I know in our staff, but in some ways, the roads will come back to us. We've trained all these people. You've got 2,000 independent prescribers, only 3 are using, exaggerated for effect. But that's that sort of theme. So how do we obtain some sort of not? I know you've been scrabbling around trying to get the numbers. Sorry, bit of a loaded question.
Okay, so the payments for placements, I believe, is generous in Wales. We are much more generous than England. What we're trying to do, which is what I just alluded to, how people are starting, the light bulbs going on now. So, which is great to see. So if they take undergraduates, trainee pharmacists and pre-registration pharmacy technicians, and they commit to that and they keep the quality, they can have a funding flow that actually generates income, and they can employ somebody else who can. So it's about, this is how much as a whole package you could get if you, but it has to be through a quality lens. And that gives you an infrastructure that actually supports increased capacity. So, I'm relatively comfortable about the amount, but it's about best use of that amount, which is what we're trying to get people to realise, that not to look at things in silos. With regards to the independent prescribing, I absolutely agree with you. I do think the as we roll out the non-medical or independent prescriber, the competency assurance, where people have to demonstrate annually, how they're using their skills and how they are being peer reviewed, that they are still practicing competently, will have two things. So if you are a prescriber and using your prescribing, you will have to go through that system. If you are an annotated prescriber, and we can get that detail, and you're not using it, the next question is why not? And what do you do about it? So I think there are things that are starting to roll out. It's not going to happen quickly, but I think we would be able to see how many people have we got who's prescribing, who is actively engaging with patients and using their skills to benefit of patients and NHS. How many have we got who aren't, and why aren't they? And I do think there's another point about independent prescribing, which I know our regulator is looking at, because all of our people will be coming out as IPs in 2026. Do you keep that badge for the rest of your career? Because you probably shouldn't, because actually if you're like me, never using it, I wouldn't be able to call myself an independent prescriber. And if I want to go back, I'd have to be trained.
I can say, well, I've got one that kind of linked to that, which because obviously now you're saying with doing the MPharm courses, they've got to have that emphasis on technical practice experience, etc. Just before I bring in the others, are people getting that sufficient exposure? Is there any struggle to give the students enough clinical experience in terms of it?
We're actually oversubscribed for undergraduate placements. So if you didn't know, it's making sure they get the right experience with the right people. But at the moment, we don't have any concerns.
We don't. So that's great. Right, now all hands. I saw Nick's first actually. So Nick, Tom, Lisa.
I guess looking at it from an optometry perspective, do you want me to address it? It's similar themes across most healthcare professions, I think. Do you want me to address it at that point now?
I thought bring it into your paper because I am conscious a little bit of time. So Tom, you want?
Yeah, very briefly, I'm sure Margaret is right about the amounts that pay for those placements. That your other point about consistency across professions is not something we have. And it comes back to your point, Judith, about the overarching view. There are differences across different students. Optometry is one which we're involved in discussion now because there's a change to the undergrad optometry course and they're integrating placements. What is our role in that, given that we have that role there built in others? So that's work we're working through with a flag with Welsh Government about this approach.
And I think that's quite a few things to then. Number one, it's sort of if you are an independent prescriber and you are a registered nurse, the result you're on the NMC register, therefore they have to demonstrate through validation that they are utilising it. But nevertheless, it's not there for the healthcare professions. So the HCPC doesn't have that, but actually Margaret is absolutely right. And I think that's to work with the current workforce and the current health boards to say how do you accommodate it, because it's independent prescribing. And there's others actually coming out as prescribed already with a different set of skills there. But you're right to ask that question. But I think on your group, actually, it is multi-professional actually in that focus as well, which is really helpful. So I think we're looking at this from going forward together and how people utilise the skills to effectively and efficiently.
Thank you. I think it was a very interesting discussion. Thank you for your update, Margaret. We were asked to note the report for insurance, which I've done. Thank you. Nick. So we already know where one of the questions is going. But again, if like to bring out highlights from your report.
Yeah, thank you. I think that's the crucial part, isn't it? That you alluded to there, Jill, is the value base on what we're doing. So we're working quite hard to try and get that. In terms of highlights from the report, obviously you can see lots of good things, fill rates and completion rates, etc. Satisfaction of the courses that we commission are also traditionally quite high, and they compare well to national comparators and other comparators across the university. I guess the key thing that I wanted to bring was around that reporting data from how reports when they're getting services in place, and then how we're measuring impact on the value for these higher qualifications. What are they needing to service? So I can talk about that now. I'll start to kind of allude to what you're asking, Jill. So I think for us, what's really key, we talked about it last time, is demonstrating that we're commissioning these, but then actually the individuals who have those qualifications are using them in the patient pathways and using their extra skills and knowledge on patients. So the complexities there are one, that health boards, because it's fairly new to it last time, they haven't rolled out everything within each health board to maximise the use of these qualifications. And last week there was a meeting, and all the health boards now have started to roll out at least half of them. So that's good news. So we should have, I'm optimistic about better news on the glaucoma and the medical retina stuff, how that's filtering through to practice. The data is challenging in terms of what we will be able to do. It's not in our control, the data, in some ways, because it's the clinical leads of the services, the Welsh Health Services, but we work closely with them to get the data to say, okay, which practices then are offering services. We can get that data and we can then filter that through, okay, we sponsor commission somebody from that practice, so that's a tick. So again, I'm optimistic that I can bring that forward so we can start to see, and it's really crucial for me to see, well, okay, if they're not, why not? Have they moved on? What's the barrier there? Why are they not using it? Was it just nice for them to do some qualification, which is great for upskilling and general patients, but not great for the reason behind our commissioning. The other thing that's of interest is that the crucial ones, like independent prescribing, they're really slow, because what happens is that there is the current situation is that the students do the academic part for qualification. They then have some experiential learning to do in placements. Those placements up until September 2024 had to be signed off by an ophthalmologist, so a different profession, a medic, and also they had to be done in a hospital, or at least most of it done in a hospital. From September 2024, we can actually get sign off from an experienced IP optometrist, so that will help us. But what it means is that it's a slow filter through, and often there can be years from the time that we commission it till they're fully qualified, having done the placement. Once they've done the placement, they also then have to do an exam, which is done by the College of Optometrists. So there's lots of barriers, and we only can affect the first academic part. But what we've been doing, as Tom alluded to, is actually trying to create more capacity in placements by having placements in optometry practices that we can now do thanks to the regulation changes, and then overseeing a bit more of an input into how placements are doing. So we're trying to increase that capacity and reduce backlog of people that have done qualification, haven't quite finished their placements. It's slow, so what we find is the data where we might commission somebody 2 years ago might only just be coming out to be able to provide IP services now. So that's part of our challenge. The point about okay, that Margaret raised, well, somebody who is IP qualified, are they using it in service and are they continuing to use it in service for the rest of their clinical time? And that we have a regulator that asks people to do additional training and asks people to do additional CPT and get it signed off, which is great, but that doesn't actually mean they're providing it in service necessarily. They should just be doing that as a tick box. And I think it's, for us, the relationship we have with the clinical leads is key, so that we can see where they're providing things in service by the detail of the claim forms from that respectively. And we can see which practices are offering services. So that would be to me, that's it's almost like our gold standard, rather than, well, because they have to stay on the register as IP, and but from the regulator's point of view, they have to do these additional training and education as they go through, but that doesn't necessarily mean they are providing service. So for us, it's about, are they providing service? So very keen to get that later. I've gone on a bit of a rant.
Thanks, Nick, and that was a great report. Open up to questions, Judith.
Yeah, thanks. Thanks for the report. I suppose I was thinking about this, and particularly the area highlighted you focused on, from the point of view of a patient. And, if I'm sat on a waiting list for 2-3 years, which many in this field are, the fact that my local health provider is not implementing something which might speed up my treatment, I think is unacceptable. Linking that to what the Cabinet Secretary said last week, and David, you were there when he talked about once for Wales delivered locally. He talked about new practices, transformation, adopt them, adapt them, justify why you're not, and that he would direct implementation where necessary. So I just think, and I know I'm pretty sure the chair's going to have it in those conversations, but there is something about how we fit into that, how HRW fits into that debate to say, we've done this, here are these people, we've assured the training, we've got all the measures ready to go, over to you, and then what's the reasonable timescale to implement, and where that's not there, what do you do about it? Because I just think if the public knew about this in the areas where it's not, I think it's quite worrying actually. I know how long some of these lists are, as I'm sure you do and colleagues. So I think it's a really important point that we probably need to think about. But it just came to mind. I was reading this, having heard what the Cabinet Secretary said last week, that this is a really good example, and there are others in some of the other, certainly in the nursing paper, there's some as well about this. So you're very clear, wasn't it? So maybe we'll move it forward.
I think it is about how we, certainly from our perspective, when people apply to do an IP course, we actually ask them, what service are they going to provide? Where do they work? Is there a service there? Because actually, if there is no service, then we're not going to invest. They have to be able to demonstrate to us that they are enabled to provide service. Can't force them to provide service, but they are enabled to provide a service. And I think we do have a duty through our investment to make sure that there is no blockers to them being able to provide that service, whether there is a service available. So that's personally what we do in pharmacy, to try and make sure we are investing in the right people to do what we can.
Speaking in terms of in optometry, you'll often have an employee because they're contracted service, and the practice side where they're providing service if it's a service investment. So we actually ask the practice owner to countersign the same as they will be providing service on completion. And I think that's our kind of due diligence in that region. It's interesting, I was talking about something else this week, and they were saying, oh, we get them to part fund it so that they know they've got an investment in it. Which is interesting.
But it's the same again, so therefore independent prescribing for these this is a post registration responsibility. And it's once again, it is the health board to put forward those staff in order to undertake that course. So this is where that's their responsibility again, isn't it? Because they wouldn't be putting it forward, unless they do that service need is there. It's a bit tricky. I hear what you're saying, that it's a few different terms of, how do they utilise them, but it's that responsibility.
Oh yeah, I'm not saying it isn't, I'm just saying there are various levers, aren't there? There's a lever
the leverage
to carry some sticks.
But the leverage is probably a reminder, and we do what you said, let you help us know. This is actually what you try, on an annual basis, they know to what they are requesting, and they received as far as training. So they need to take that forward.
I've got one tiny one, which was in your quality assurance on the modules, and this might be a small number issue, but the glaucoma 2 for September, the negative seemed a little bit higher as we saw the other results in terms of, am I satisfied with the overall module? I say it could be a small numbers flip, but I just wanted to be worth having a little look at that in relation to.
Yeah, there was independent prescribing as well. Yeah, I haven't yet, is the honest answer, but I'm going to give the PTT next week. I'm going to go through this and ask if there's any reasons why we think so.
Yeah, that would be very helpful. Thank you. Thank you for that, Nick. So we're asked to accept the report of assurance of quality processes in the Royal Commission. Thank you for that. I am chairing abysmally. I'm very conscious we're already running over time, so apologies for that. So no pressure here. We're on item 2.1.5, the nursing and health professional.
Okay, so this report is divided into essentially 4 areas, which relate the organisation of that aspect of the visit. So that's in relation to pre-reg, placements, post-reg, and then work-based learning. So we begin with some information on where we are at the moment in terms of the current focus of work. And that relates to preparation for the contact meetings that are taking place in November. We're currently in the midway through those. Some are taking place, some are still to take place. There's performance management annual questions related to the duty quality that we are gallery and universities have at the moment. They're completing it ready for return by the 6th of December. And there's some information there on some other bits of in response to discussions we had with these partners. So, for example, in relation to the nursing pipeline of the Pwyllgor, where they explicitly said what the specific pieces of work and meetings like that. The students' complaint register being developed, notably in this work ongoing in relation to that. There's information there on the 39 pre-registration concerns that we're currently managing. And there's a table that provides some information on the areas that they relate to and the stage of those concerns. The majority are in stage 1, there's a few in stage 2, and then there's one in stage 3, which is the focus of some other discussions and everything like that in committee. We're currently evaluating the responses of some other concerns, and we're doing some work with them, for example, in relation to the NHS action plan. So those policies that achieve more than 7% overall satisfaction, and they require the smart action plans to ready, and we see those action plans as well. We're working with the universities to discuss, consider those concerns, and ensure that action plans are implemented and others can manage that then successfully. In relation to the bursary situation, the recruitment involved, the recruitment position is at the moment and has just gone through the latest update. So we've got a very update from the previous meeting on the 6th of September. So for the next meeting, we'll have an update on where we are as we reach the kind of census point for these surveys and the position the university they're in. In relation to bursary, we've got a table there which has got information on the number of roles that have been advertised against the number of bursary students. And there are 3 programmes here that highlight where there's a significant discrepancy. And where there are those discrepancies, then we're actively managing that. And that's at health board level, and we use information on the commission numbers or the numbers that were submitted by IMTP to hold health board to account for the number of quotes that they should be developing for the graduates coming in, because that relates to what they commissioned earlier. There's an issue there that's noted in relation to practitioner training pathways. These are programs with very small numbers, and they can be susceptible to the arrangements that we put in place in specific locations to support those programs, so they're vulnerable to changes that occur locally. There's information linked to physician associates. I think that we're all aware of some of the challenges that are facing with physician associates, and there's detailed consideration of how we're going to work in that space. There's an issue there in relation to midwifery streamlining, where Cumham Morgano has contacted us because only 12 graduates were recruited through the recent streamlining, where the requested 33 through their IMTP, so that discrepancy is causing concern. And again, that's evidence of how we work with partners in relation to us raising concerns and then them raising concerns, and we seek to be responsive to those. And we're hoping to get some information on the complex reasons that are likely to be underpinning that. And when we have information on that, we'll be able to take appropriate action. There's information on the placement programme, with the number of programmes we have in this area, and the number of students that are involved in some major operation to ensure that placements are running smoothly. So there's a lot of information there in relation to, first of all, areas where there are issues and they all being managed appropriately. And then there's information in relation to developing infrastructure and to ensure that we've got sustainable placements on an ongoing basis. We've already heard from Anton and Margaret in relation to the issue of Princess of Wales. After that, I've gone through has been looking close communication about what happened in the early management of that situation. We had the same situation in relation to nursing and health professional education. And there's been minimal impact there. Students have been relocated along with the services that had to be relocated, so there's continuity of experience for them as well. There's a little bit of information in relation to postgraduate education. That's in relation to some of the tenders that are currently live, and there's an update coming in from Education Procurement Board there on the agenda, so there's an overlap with some of the issues there. There are some issues which we are waiting to understand exactly what our role will be. So, for example, in relation to RNE, so the Register of Associate Procurement, and then think about the requirements to make sure that we've got all the information we need. Finally, in relation to work-based learning, there's some information there on some of the recent developments. Margaret mentioned our success. In her area, it's worth mentioning the collaborative work with the National Imaging Academy of Wales and for the computer tomography choreography and level 6 assessors course. And then there's also a bit of good news in relation to the Agored company quality assurance visit in relation to the nuclear topic award, which received a positive outcome. There's a really positive outcome with no recommendations of requirements, which was an excellent outcome. Completely inadequate that with them, so indicates that the infrastructure will put around that is getting it.
Thank you. That whistle stop tour, Ian. I'll open it out to questions. Jill, I'll go first. I know. Yeah, I'm doing this stuff with you.
Yes. Just a couple of questions. Very comprehensive paper and very clear. The numbers, and I know it's an imperfect science, but they do look particularly out of kilter in places, don't they? And particularly, so if you just glanced at ODPs, just as one example, I mean, it doesn't look right to me. And by the same token, you can't train people when the jobs appear in the process. Now, I know the IMTPs have always been imperfect in workforce terms, but Martin's going to cringe now because I'm going to come back to the map of the professions, and I know we've talked long and hard about a workforce plan for Wales, and we can't quite move that forward necessarily. But there still feels to me, if we're 7 years in now to HEIW, and I still don't feel as if we quite have that total picture of what is wanted. And I know it probably is the work, Alex keeps telling me it's the workforce plan for Wales, but I still feel if we look at this, and it isn't necessarily within our gift, but I still feel it doesn't give the picture that we would want in terms of satisfying what is needed. So we are training more, and we've talked about whether that's having an impact. But here we look as though we've got figures that are out of kilter in terms of what can we do, I guess, if that's something. These are those questions to answer.
Well, Martin might bring on this as well, but it's in terms of OTPs as an example. So what we mustn't forget is that the national programs that we have in place as well. So there is actually a very specific national program looking at 6 goals and all the diagnostics and everything. And this is where, as an organisation, we actually feed into actually that workforce element. So in terms of actually the theatre workforce, there is a piece of work currently being undertaken to look at that. So this is where this is not just the one stream of work. This actually impacts and informs a lot of that strategic actually political networks that we've got across and all the minister it's zero priorities. So I can honestly say to you actually the theatre workforce is a dedicated current piece of work, and we are involved in that. And of course that would feed into that. ODPs actually in Wales is part of the healthcare science network. Don't want to talk more there because as well as an HP, but nevertheless. So there's actually a lot to do there as well. And there's a lot of work currently being discussed in terms of transformation of that workforce as well. In terms of you've got, theatre nurses, you've got ODPs coming through. So what do we need going forward? And that's actually going to a conversation piece that you're going to need to have. But I'll handle that. And people know about these figures, don't they, Martin?
So we've done a piece of work subsequent to preparing this paper, and we've gone back 3 years to look to see what the health board submitted as part of their workforce plans. And what they submitted in their workforce plans is similar. I'll come to ODP, which is the exception. What they've submitted in their workforce plans is similar to the numbers graduating, and the numbers graduating were probably just a little bit below what they asked for. We could do commission based on what they asked for.
Yeah.
We then commissioned with the most appropriate education provider, and we mapped the placements in those health boards against the numbers they asked for. There's a huge discrepancy between the number of jobs they're advertising and what they asked for 3 years ago, and that's what causes problems. Now ODP is a bit of an exception because this is the last year graduating from Cardiff University. We had one provider at the time. It didn't really meet all their needs, all Wales needs. They didn't fill all the places we commissioned. But the number of jobs that have been advertised exceed triple what they asked for. So something's happened in ODP, as Lisa alluded to. Going forward, we will have more ODP graduates because in the new contracts we have it in University of South Wales, Wrexham University and Swansea University. So we have 3 regional providers for it, and the numbers are going to be higher. So there's a huge discrepancy there as well. The other piece of work which we are currently compiling, which will really, really inform this, is we have sent questionnaires out, surveys out to all of our graduates and asking them where they've got jobs. At the moment, this is quite theoretical. How many jobs have been advertised, how many graduates we got. We are triangulating that by looking at then the responses from the graduates, tell us where they've gone. So in about 2 or 3 weeks, we will have had probably about 89% of those responses in from the graduates, because they do tell us where they've gone to work.
Thank you, Martin. That is good. And that one. Ian.
There's some of the infrastructure as well, so recognition of GDP is increasing. And so we've got a fairly new profession, which is growing in colonies. I think that the youth providers across Wales, there's market taking place to increase awareness of that as a career route. So we've seen the number of commissions increase over the past few years. It's going to continue to do so in line with our growth of the market as well. So the market has to be growing with a big push of the application.
Thank you.
Just on the point of discrepancy between the ITPs that 3 years ago and what the actual demand is now, do we understand why there's such a discrepancy?
So this has been escalated through the education tribunal cycle, which Graham chairs, and we're basically now holding a mirror up to the health boards to say, this is what you asked us to change. Okay? These are the number of jobs you made available. What's the discrepancy? What's happening? What are you going to do about it? Sort of thing. We've not got the answers to that yet, but that's the process that we're in.
Judith.
Yeah, thanks. Just on that point, having very recently come out of the help, there's a lot about what you are hoping to implement in terms of change and what we're actually end up doing in reality. And there'll be all sorts of things that, and you'll know this as well, all sorts of things that prevent you from transforming, making changes, closing things, moving services into community, really sort of moving people from out of hospital. So I think that's why what Alex also always says about having this longer term plan, and in Wales, longer term workforce plan, actually then everybody has to sign up to making those changes, because that is not there. Actually, there is, you put in the plan, there's no pressure anywhere on health boards if you don't come up with a basis for people you've said you've trained. Actually, there's nothing. So I think we have to alter that conversation, and I think it's going to be part of that as an organisation. So I have a very, very specific question. Please can you tell me, I see on page 50, what is the child field nursing?
So basically, actually, what you've got to do in terms of professional registration, you've got the field of nursing. Just add this.
Right, so it's in relation to that.
You've got a specific for somebody who is treating children in.
No, I didn't make the connection because it's not referenced anywhere else. So it's the fields of nursing. So I get it now.
Out in the community.
No, I'm saying
No, it's just for this right. Yeah, we were joking.
I sort of knew it was a busy career field, but I couldn't get my head around it. In which case, that to me is really concerning, actually. I mean, I can see that you've got things that are happening, but the fact we haven't got enough clinical placements for people in that field is really worrying. But I can see it's a comment rather than a question, because I can see that you are taking that forward. But, that, and the simple words is that you train people and they can't do the clinical placement anywhere. And they're not going to stand in on it. That's really worrying. Now I know what it means.
I know. But yeah.
Yeah, so we're doing a lot of mapping around our placements. Since HIW came to being, we've probably doubled the number of available placements across Wales. We're doing a lot more in the community, but we still get in these pockets that are sometimes blocks to us increasing numbers. And we try and take placements as a blocker for commission numbers out of the system, and it's still in a couple of areas. It's something we're working through, something we will get. The child field is a really popular field of nursing as well, because we get loads and loads of applicants. We always fill our places, and we can actually overfill our places. And in a couple of instances this year, we have agreed with universities that they can go over their commission numbers, because we know they've got sort of lower numbers on adult and mental health, and we know child nurses can make an impact across a range of areas. So there is pressure on this area.
So one final thing is the
You're eating into coffee time. No, I don't mean that.
Page 52, sorry, page 10 of the report about the clinical associates apps. It's not a question other than I'm assuming your feedback from the stakeholder event, but it's so frustrating having had a lot to do in that area of service. I just know the demand for those people are there, and that it's just having a, what we can do to get change in mindset to look at how those people can really help in that service. So I just want to say I'm very frustrated to support you in everything you're trying to do, and it would be good to get feedback from the event, which presumably is happening
Next week.
I was pleased to see that it was escalating. So
Yeah.
After our last discussions. Thank you. Okay, we were asked to note the report for assurance, which we have done. Thank you. Item 2.2, the update on the quality management approach. Tom, you're taking this one?
Yeah, appreciate you are well behind time, so I'll keep it brief because this is an update, and we have had discussions as well as reviews, and your questions today, in fact, directly relate to the purpose of this work. So I think it's worth starting, and it's not starting from the fact that we didn't have anything in quality across the systems. You can see today the range of programs, the different responsibilities in quality. The purpose of the work that started with that in May is really to ensure we know what we're doing, we know what our functions are clearly in relation to quality. We're reviewing them, we're improving them, and we've got that consistency of approach so that we have that reach to the Welsh Government, partner organisations, because we do have a central role in relation to quality with all these different professional groups in training providing so much. So the first phase is being completed. We've mapped now across all our programs exactly what is being done in the organisation. That has been useful. It has identified areas, partly driven by the different regulatory landscape of expectations. So very well advanced expectation within the GMC medical regulation, which gives us the fairly advanced process and quality management system that we have. What we're trying to do here is align everything where it should align. And broadly speaking, we all have planning and improvement functions in our different professional groups. And we've aligned those. It's the quality management of the environments, and then the quality assurance when others align with our providing it and knowing what our roles in. So actually, there are a few areas we've identified where we can bring that together. But I think it goes back to Judy's point. The fundamental gap where we need to improve is the helicopter view of everything that's happening in all of those areas. And actually, we believe that the next phase, which will start before Christmas now, which is some changes to how our internal governance structures work across our different areas to create a single quality group that looks at all of this. So the issues, for example, is what's coming out of a health board mirrored across all of those professional areas. It feels like there needs to be another area where we bring that for oversight within HIW across all our departments and teams, which provides us with that ability for that consistency. If we've got all of that really, and I don't think the gaps are very big at all. We've got it all there, but the questions you're asking are effectively today: are you having that? Are you triangulating? Is that consistency of approach? And it's not just triangulation; it's the consistency. We sometimes find we're trying to do things in some areas that have already been through and been done in a. If you share that information to the right joined up or what effort, source, and improve quality. So this is the purpose of the group. The groundwork has been done. The paperwork to inform the processes, the quality management system, etc. That's done. That's just having an audit trail, the process you can refer to. The internal structural stuff is the next step. Next step will be having the first group meeting to thrash out how that will work. The aim being not to create extra layers, the aim being to make it more efficient. So the plan here is to bring groups from the different areas together, but perhaps removing other areas that are happening in silos. So it'll be a reframing of how we bring that. And I would hope that that will be, when we come here, some of those overarching themes across all the professions, rather than just picking them up and trying to join the pieces sometimes as we do. So it's progressing well, everybody's on board. I think the connections we touched on, Lisa mentioned, with all the outside, they are in place. They need to be refined, but mainly because of the receiving end and what they actually do with the information, rather than the information not going to it.
Yes.
And the IQPD has been a useful development there, plus us flagging that we don't expect any secrets. Our approach to quality is sharing with information for collaborative partnership working. Therefore, we don't feel we should be in a position of saying too much government about these policies. With that, everything we tell them, the health force they told. So all our partners in the health force know what we're telling Welsh government. We're saying to Welsh government, we would expect you to have those discussions in those meetings. It's not a rich source of information when you have your discussions with those partner organisations. Not just about us giving you the information that we're looking at. So there's a lot of work going on to refine that. And I think the final thing we were looking at, we finished the scope and work around surveys that happened as well. We hear a lot in this committee about surveys. All of them are really professional, very long, well, most of them are, and therefore you're trying to triangulate costs. For some time now, National Education and Training Survey, multi-professional has been done in. So we've met with their group. We feel there may well be a place to streamline some of the data we have. But at a point in time that gets data across professional groups in common environments, may go some way to addressing some of these issues. Let's discuss them. We're going to pause there, but it was really just to update you of where we're at, where we're heading, and what we see as the impact. So just sort of stopping that we're incorporating into the sort of business as usual side of things now, as opposed to the scoping for the.
It's really helpful update on Jill.
Just very, very briefly, Chair, just to say I'm extremely excited by this type. And it's exactly what I think when I first joined the committee I was expecting to see, and I struggled valiantly, I think, through your patience to ask all those questions. So I'm really, really pleased. That's what I wanted to say.
Excellent. Well, that's a good comment. Any other comments? Similarly, I think it's an excellent paper and for the update. So you can see the work continue. Excellent. Thank you. We were asked to receive and note the update for insurance, which I think we have done. So we're in part 3, which is the strategic matters. We have a highlight report from the Education Procurement Department Board. Yeah, that's you again.
Right, so this is an actual report on the activity in relation to the procurements. So there's information really on current activity. You'll notice that a current theme is that there are potential delays to issuing contracts because of babysitting data and reporting issues. They are not holding a material threat to the contracts running. So even though there are issues relating to some contracts that are being issued in relation to some procurements that are in process that take place, we don't envisage that those issues will contribute material risk to the procurements. So there's information there in relation to the psychology contracts which have been returned, and those programs are running. And community nursing is the same, that we've got a contract on universities. We're proceeding to award for the independent authorisation of transfusion. That's in the committee. Ultrasound, we consider that that's we're approved to award. Independent prescribing was intended to go live until the 27th of October. That was actually extended, and I believe that goes earlier this week. So the timeline will follow on for the evaluation of that now. And then we'll talk the mental health education ultimately we refer to COMA. That's in process and will be going live probably about March 2025. And then enhanced and advanced practice will go online fairly soon as well. And the second section of data provides some information on the risks that we are managing in relation to these registered nursing associations up again. So there's going to be some good implications for that. We're not exactly sure what they are yet, but there'll be there's work underway to understand that. And then there's some information there on the resources that we have to actually manage those procurements that are necessary. So the other risk is the sorry, I lost my track. Apologies. And so there's a few risks that are I get quite clear. You just getting through the work, but consider the implications of some of the issues that have been raised in relation to
Right. Okay, so any specific questions? Judith?
Yeah, I suppose my question really relates to MAC rating. I was struggling as to, particularly looking at the caps, why it was green when it's not actually completed on this September. So it's just a minor
So,
point over
yeah,
the
so
rating.
so the procurement risk of the caps is not a risk because we went out to tender, we had successful bids in of a sufficient quantity and we've awarded the contracts. The issue is now in our business as usual contract management. So that's going through a different risk register.
Thank you. And then finally, 1.6, what is lotting? What's the lotting structure?
Okay, so a lot in strategy and structure is us deciding with stakeholders if they're going to have one contract for Wales, whether it's going to be regional, whether it's going to be almost per household, and also do we need two different kinds of education? So we sometimes break our tender down into lots. Yeah.
Thank you.
One comment. It's around the date sharing agreement.
Good.
As
That's my question.
As an organisation, we do not enter into post-contract negotiations because then if you do, you end up with a lot of contracts that look differently, and it's very difficult to collect information the same way. So when we go out to tender, we say, this is the contract, these are the terms and conditions. Please look at them if you're going to submit a bid and give us any questions and comments we can consider, and then we can make that information available to all of the potential bidders at the same time. And of course, when bidders are bidding, they're really concentrating on getting the bid in and the quality of the bid, and they only pay a little bit of lip service by looking at the contract. And it's only if they've been successful, then do they look into the contract in detail. So what we're doing is we're making this even more explicit when we've got out the tender to say, this is the contract, these are the terms and conditions that you will sign up for. So this is an issue that we literally wrapping up now between our information governance team and the universities, and we are putting mitigating action in going forward on it.
So when do you think that's going to result? Obviously, the Oracle was saying that there's a delay because of it.
Yeah, next week.
Next week.
Next week it will be. We've got a meeting between the three organisations next week.
Okay. And are there any other further questions on that? So we're asked to know the report. Thank you. Part 4, the governance matters 4.1. We've got the draft committee self-assessment. Have it.
Diolch yn fawr iawn. Mae aros y mygiad gan mae'r papur yn y Cymraeg. Felly papur yn gofyn am gymeradwyeth ydy hon. Bydd aelodau yn ymwybodol ein bod ni yn cynnal asesiad o waith pwyllgor olynydol. A'r pwrpas hynny ydy gwella rwydd y pwyllgor yn sy'n gwersi o'r gwaith yn gwneud y blwyddyn ar fyd. Yn amlwg, mae'r holiadur hyn yn asesiad yn holl allweddol yn cymodi'r gwaith hyn, a da ni eleni yn atgymell tri newid i'r holiadur. Yn gyntaf, da ni wedi edrych i cael gwell ffocws ar y cwestiynau, gwell wyleu unrhyw elfen sy'n gorgyffwrdd ar ei gilydd, a mae'r cwestiwn hynny sydd wedi newid yn cael ei ymwnesu yn paragraff 3 o'r adroddiad. Da ni hefyd wedi newid y holiadur mwyn bod ni'n gallu casglu mwy o adborth ysgrifenedig, ac yn olaf, da ni hefyd yn adnabod bod ni yn mudo y holiadur i Microsoft Force. Felly, da ni'n gofyn sgwrs o dda bod y pwyllgor yn ystyried ac yn mewnblygo'r sgwrs o dda.
David, any questions? I've got a specific comment. Oh, sorry, Jill.
I'm making the same comment.
It looked quite long.
Yeah. Mine was you kidding me.
Yeah, it looked long. I was assured because questions have come out, it is actually potentially shorter than we did before. But I think the difference is that the actual trying to drill down and get reasons for responses, which won't be mandatory. You won't have to put everything in. But I think when we reviewed it last time, particularly if somebody had given a slightly less positive response, we didn't necessarily know why. So I think the idea is that we try and capture, and it's more useful document. But I have the same thought. But it is actually fewer questions. I understand. Yeah.
It reflects the recommendations from the board last year, which was to seek more feedback.
It's to get the feedback. If there are specific,
there are less questions.
Yeah, there are less questions, but I think it's just, and I think it's the way it's printed out, because obviously it'll be electronic, won't it? When you come to do it, so it won't feel quite so extensive.
And just emphasise that you don't have to provide further information, so it's
But if you have a burning desire, and if you do say this is not, something that it is an issue for us to be considered, we need to know what it is that we're considering, not just that things. I think that's particular. Any other questions? No, in which case we were just to consider and approve the content of the committee effectiveness review document. And when are we going to be asked to complete it? When is it coming out? Do you know?
Come out to the next couple of weeks, and we'll ask people to complete it before the end of the year.
Okay. So 4.2 is the board work programme. Yeah.
Yes. Diolch yn fawr iawn. Da ni'n wedi papur sy'n gilydd sy'n amlellu gwaith y Pwyllgor ar gyfer y flwyddyn nesaf. Dwi'n cymryd gan sal yn pan dwi'n cael gyfle allan bach o ffurf, felly mae'n dim ond pwysleisio un elfen, sef fod rhaglen gwaith ar gyfer y flwyddyn nesaf. Fan waith, bod ddim yn concrete, felly os oes angen i ni newid yr agenda ar gyfer unrhyw Pwyllgor i ni adlewyrchu unrhyw datblygiadau. Dwi'n hawdd i wneud hynny wrth gwrs.
Questions on the board work programme? No? Okay, we're going to ask to approve the 25-26 Education, Fishing and Poverty Committee board work programme. Got that? Very much. So then part 5, which is the for information and voting, which was the Chair's report on the stakeholder group. Stakeholder reference group was held on the 21st of October. It was an in-person event this time, which I wasn't able to attend. Jill, did you attend that? Yeah. So you maybe, if there's any specific questions on this, Jill might be better placed to answer them. But what I understand was that it was well attended and there was good representation from a lot of all parties in terms of who was there in the room. And was a presentation on the strategic context and the emerging plans. And it's what the purpose of the meeting was to enable the sort of tabletop discussions to help inform our priorities for the IMTP for 25 to 28. And there was a good range of discussion and topics that came forward with regard to feedback about our attraction and retention, our multi-professional learning, how, and I've of course been one of these in the past, I'm very pleased to see that AHPs would be prominent in plans, etc. So, Jill, was there anything specific else that you wanted to raise? Or?
No, I think it worked better. That doesn't even because it's a time and a place, obviously, both. So I think it worked quite well. I think there could be more representation.
That's interesting. Good. I'm hoping that we're going to have another one that I'll be invited along, so that'll be good. Yeah. Okay, thank you very much. We're asked just to note that report. At which point I haven't been advised of any of the business, so I will close this part of the meeting. We're due to meet again on Thursday, the 6th of March, which sounds quite a long way away, but it will come around very quickly. And I'll conclude this meeting by saying, in accordance with the provision of Section 1(2) of the Public Bodies Act, Admissions to Meetings Act 1960, it shall be resolved that representatives of the press and other members of the public be excluded from the latter part of the meeting on the grounds that it would be prejudicial to the public interest due to the confidential nature of the business acting. This section of meeting is to be held in private session. Thank you very much. Can we stop the meeting now, Fiona?